So we're going to take a presentation we skipped yesterday, right now, before we continue. And that will be cardiovascular diseases in pregnancy. We'll take it, Dr. Abiodun will be anchoring this session. Please, a round of applause.
Good morning, everybody. It's a great honor to be here to take this presentation. But before I go ahead, I would like us to give another round of applause to Dr. Chima and Amina for that brilliant, very, very brilliant presentation. Fantastic. Kudos to you guys. So this morning I'll be talking about cardiovascular diseases in pregnancy. You will all agree with me that this is a topic that is very, very important. We all know that, pregnancy is a business that goes, all through the year. I'm sure some of our female folks here are pregnant. And if there are none, I'm sure there are men here who are pregnant by proxy. Is there any man pregnant by proxy here? Okay, yeah, thank you. So next slide. Right? Is it working? Okay. Okay, yeah. Okay, so my disclosures, my outline, and then by way of introduction, the cardiovascular diseases are the commonest causes of maternal mortality amongst pregnant women. And this is because the incidence and the prevalence, have been on the rise. And the type of CVD that you have depends actually on the region of the world, where you are, where you live. Generally, we know that hypertensive disorders, are the most frequent during pregnancy, accounting for as much as 10% of all pregnancies. And when you live in the Western world, congenital heart disease is the most frequent, but in the non-Western countries, you see more of rheumatic valvular disease. So from the work that Karaye and co. they have done, the Peace Registry, we know that Nigeria has the highest burden of peripartum cardiomyopathy in the world, with a mortality of as much as 50%, at 1 year. I'm going to be talking a bit more about peripartum cardiomyopathy in the course of the presentation. So these are the spectrum of cardiovascular disease that you can have in pregnancy. We're also going to be talking just in a tiny detail about, one or two of them subsequently. So talking about the risk factors for pregnancy these days, you will beginning to see increasing age at first pregnancy. By the time you're getting pregnant for the first time at 40 or more, you can be sure that some of the cardiovascular risk factors, like hypertension, the commonest, diabetes mellitus, obesity would have set in. And also, there is this improved treatment of congenital heart disease now. Even in Nigeria, there are many centers that do surgery. Last week, my center, Federal Medical Center, Abuja, operated on a couple of cases, congenital heart diseases. And what that means is that for the female folks, they'll be getting pregnant later, and that can then serve as a risk, for the development of cardiovascular disease. Also, autoimmune disease, systemic lupus erythematosus, antiphospholipid syndrome, there are some of the autoimmune diseases that can predispose to cardiovascular disease. We also know that nulliparity, multiparity, multifetal gestations can predispose patients to develop hypertension, particularly preeclampsia, as well as long pregnancy intervals. And we know from observational studies that assisted reproductive technology, from the hormonals that are used for these women can increase their risk to developing hypertension. So why is pregnancy so delicate? Why is it so delicate? The reason or the answer lies in the profound hemodynamic changes that happen during pregnancy. And these changes typically they start in the first trimester, the peak in the second trimester, and then plateau in the third trimester. So, and what heralds these changes? It's an increase in the cardiac output by as much as 50%. Okay, and maybe by third trimester, yes, you have a reduction in cardiac output because of the compressive effect of the gravid uterus on the IVC. Okay, and by labor, delivery, and postpartum, when the placenta has been delivered, the cardiac output goes back up. So you can see that this can even make the normal heart to seem as if they have symptoms or signs of cardiac disease. So these changes, these seesaw changes, going up and down, can put a lot of intolerable strain, on an abnormal heart. And so because of this, it's important that when you see pregnant women with suspected cardiac disease, that you take a detailed history and you examine them carefully. We should measure blood pressure at every visit for pregnant when we encounter pregnant women, and we should listen for pathological murmurs. Okay, so if the murmur is very loud, if there's a trill, if it's a diastolic murmur, okay, chances are that you are dealing with a cardiovascular disease. Okay, yeah. So of course, urinalysis is also important for proteinuria because some of these patients may come down with preeclampsia somewhere down the line. So this brings me to our first quiz. So because I try as much as possible to make this an interactive session, so I want to test our knowledge of what the symptoms of normal pregnancy is. Have we been able to join onto the poll? Okay, yeah. Oh, yeah, okay.
The polls can be joined now, please. Cardiocare.ng/polls, so you can answer the questions.
So can we join at cardiocare.ng/polls? Has anybody been able to join? Not yet. Okay. Okay, great. Wow. Fantastic. So it's actually a true or false question. I think I didn't tell the Mr. Ella about that. So yeah, so you're right. Can we take it up, please? So yeah, so all those okay, I think on that poll we have dyspnea on exertion. There is also autopnea. Yeah. Okay. Yeah. Thank you. It's back now. Okay, I can remember now. So there's dyspnea on exertion. There's autopnea. So dyspnea on exertion, autopnea can be seen in normal pregnancy. Okay, but when you see angina, dyspnea at rest, and PND, these ones are not features of normal pregnancy. So it's important that we get that. So the next question, there's also another question on the signs of normal pregnancy. Can we go to that, please? This is not working. Yeah. Okay, great. So the following are signs of normal pregnancy. Jugular venous distension, is that true or false? Apical S3, is that true or false? Basal crackus, is that true or false? Prominent left and right ventricular apical impulses, is that true or false? And peripheral edema, is that true or false? Can we take the poll now? Yeah. Yes, your second question.
No, it was set up wrongly. It was set up wrongly.
Let's move on. for the normal signs of pregnancy, all these signs that you have on the screen are normal signs of normal pregnancy. So jugular venous distension is true, apical S3 is true, basal crackles, that's also true, then apical impulses is true, and as well as peripheral edema. So all these can be seen in normal pregnancy. So you can see how difficult at times it can be to separate normal from abnormal in pregnancy. Okay, so next slide. Okay, yeah. So with respect to evaluation, one of the basic screening tools in pregnancy is the ECG. Okay, so it can help you to identify whether there's a need for further study. And echo is also the preferred imaging modality in pregnancy. Okay, so for echo, the reason for that is because it is safe, it is widely available, and it is relatively inexpensive. So if you see any pregnant woman that you're suspecting may have a cardiac disease or a cardiovascular disease, echocardiography is the way to go. Now, the other tests are in the purview of a specialist: exercise testing, cardiac heart, MRI, genetic testing and counseling, prenatal diagnosis. These are things that you expect the specialist to do for women that are pregnant. Okay, but of great importance is the maternal cardiovascular risk assessment. Okay, next slide. This is not going. So for cardiovascular risk assessment, it's important that for every patient that you suspect may have cardiovascular disease or that have cardiovascular disease, you must assess their risk. Okay? Because pregnancy with cardiovascular disease is associated with a lot of morbidity and mortality. Okay? So, and one important tool that you can use is the WHO classification, okay, which looks at the diagnosis, okay, and from stage 1 to stage 4, depending on what you're dealing with. Okay, you want to? Okay. Next slide, please. And it also looks at the risk of, can you go back, please? Yes, it also looks at the risk for women, for the maternal risk and fetal risk, as well as the rates of cardiac events, and as well as whether you need to give counseling to these women or not. It also looks at which hospital they should be cared for, and the number of times that they're going to have for follow-up visit, and where delivery should happen. Next slide. So this is very, very important because oftentimes we get to see patients with cardiovascular disease and they are managed in centers where they should not be managed. These are examples of high-risk pregnancies. You know, we have pulmonary arterial hypertension, anybody who has severe LV dysfunction with an ejection fraction of less than 30%. If someone has peripartum cardiomyopathy with residual impairment, we mean residual impairment in the sense that to make a diagnosis of peripartum cardiomyopathy, you're talking about EF of less than 45%. So if you've seen a patient who is pregnant, EF comes, say 30, and you've managed, and the EF has not risen above 50, then there's residual impairment. Patients like that should not get pregnant as much as possible, you know, because it's a high-risk pregnancy. Then any patient who has severe valvular disease, either mitral stenosis, aortic stenosis, or regurgitation, also qualify as high-risk pregnancies. So these are cases that, as much as possible, should be counseled not to get pregnant. Next slide. So what are the general recommendations for management of people who are pregnant? So every woman that you are suspecting has cardiovascular disease must have pre-pregnancy risk assessment. I do that a lot in my clinic. Oftentimes I see young women in their 20s with hypertension. And at that time, what I'm able to use to control their high blood pressure are the routine drugs that cannot be used in pregnancy. So you want to tell them that, okay, I'm giving you these medications now, but when you want to get pregnant, these medications have to be changed, you know, to the medications that are safe in pregnancy. So risk assessment and counseling, it's very, very crucial. Okay, because it's at that time you will tell them about possible drug change. At that time that you may tell them for those who cannot get pregnant because they have high-risk cardiovascular disease. It's also important that patients who are moderate to high risk with cardiovascular disease are managed in centers where there are pregnancy R teams, multi-specialty pregnancy R teams. Because to manage patients with cardiovascular disease, you need the collaborative effort of a lot of specialists. You can see the echo is recommended in any pregnant patient if they have unexplained or new cardiovascular signs and symptoms. So anybody that you're suspecting, okay, I've examined this patient, I've taken the history, this may be cardiovascular disease, you need to do echocardiography for them. Next slide, please. Okay, so this is very important, and it is premised, the cardio-obstetrics model is premised on the idea of the pregnancy R theme. So when you are seeing patients who have cardiovascular disease and are pregnant, you know, it is not just about the obstetrician alone or the cardiologist. It's about a collaborative effort of so many people. So you can see the cardiologist, the obstetrician, the primary care physicians, and many of you are here today, the anesthesiologist, nursing, pharmacy. So, and what all these people will do is to plan the care for these pregnant women, starting from preconception through pregnancy, labor and delivery, to what happens, you know, even after patients deliver. Next slide, please. So, at this junction, I would just like to talk about one or two of these CVD types. I'm sure next slide, you're going to be talking about hypertensive disorders in pregnancy, and a lot of us will be familiar with this. I'm sure that we can relate with hypertension because it's the commonest, as I've said earlier. So when a pregnant woman has blood pressure of 140/90 and above, you say there's hypertension in pregnancy. Okay, and there are two categories of hypertension in pregnancy. There's a mild hypertension and there's a severe. So for the purposes of pregnancy, there are just two categories, mild and severe. Now, it is severe when patients have a blood pressure of 160/110 and above. So for this group of patients, they must be referred to the specialist. These are not the type of patients that, you know, the primary care physician or the obstetrician will sit on. Now, if the blood pressure is mild, of course, you can go ahead and manage. We'll be talking about what to do, you know, with respect to management. But in severe hypertension in pregnancy, you must refer such patients to the specialist. And when a patient has a blood pressure, pregnant, and has a blood pressure of 170/110 and above, that is an hypertensive emergency in pregnancy. So such patients must be referred to the hospital where they can have intravenous or parenteral medications to cautiously bring down their blood pressure. So there are different forms of hypertension in pregnancy. It can be pre-existing. So if someone has had hypertension before getting pregnant, or hypertension that you are recording before 20 weeks gestation. The same thing applies to the next one is gestational hypertension, in which case the patient is developing the hypertension after 20 weeks of gestation, okay? Which can be either be preeclampsia or transient. In preeclampsia, there's proteinuria, and you may also have features of ongoing target organ damage, okay? So preeclampsia is not just about proteinuria alone. It's important to get that. And it can be antenatally unclassified. So in which case, the first time you are seeing the patient is after 20 weeks gestation, and you are unable to tell, you know, whether it's a pre-existing one or it's a gestational hypertension. Now, you are able to tell which it is after 42 days postpartum if the blood pressure does not go back to normal. So if the blood pressure goes back to normal, then you can revise your diagnosis to gestational hypertension. But if it does not go back to normal, then it means that that hypertension was there, you know, before the patient got pregnant, or it was there before 20 weeks. Next slide. So this is very, very important, an important slide. As I've said, for our primary care physicians, our obstetricians, you should refer every pregnant woman with a blood pressure of 160/110 and above. Or if you are seeing a patient who is pregnant and the blood pressure control is worsening, so you have to refer that type of patient. And our target blood pressure is less than 140/90. And as much as possible, it is contraindicated, you can see in red, 3, to treat their blood pressure, their diastolic blood pressure below 80. Is that okay? So what you want is less than 140/90, but you don't want to treat their diastolic blood pressure below 80. So another important thing are what sort of medications can we use for these patients? Okay, so labetalol and alpha methyl dopa are the first line medications in pregnant women. So for your patients, labetalol, it's okay. Alpha methyl dopa is okay. And extended release nifedipine, you can see it down there, is recommended as an alternative. Okay. I also know that a lot of us like to use hydralazine. So hydralazine can be used, but as possibly fourth line. And the reason is because of its unpredictability and the effect also on the fetus. Okay. So first, you want to do labetalol, alpha methyl dopa, followed by calcium channel blocker, extended release nifedipine, and followed by hydralazine if possible. Next slide. So for the other spectra, I'll just highlight, thank you. I'll just highlight, I'll talk about them with some of the cases that I've seen in my practice. So this is for peripartum cardiomyopathy. I remember seeing this lady in 2019 who developed shortness of breath after 6 weeks after delivery. Our echo showed that our LV was dilated, which is normal, customary in PPCM, and our ejection fraction was 42%. You remember I said that for PPCM, it's typically less than 45%. Okay, so she had treatment, and by 2022, late 2022, the ejection fraction was between 56 and 61%. Also, our NT-proBNP, which is a marker of heart failure, was also normal by April this year. So the question is that she came to me and said, "Sir, I would like to get pregnant." So the question is that can she? That's the question. So, and we can answer that question by looking at the guidelines. So we know that anybody who has PPCM, any woman who has PPCM, they will always be a high-risk pregnancy. But patients that have residual impairment, as I said the other time, should be encouraged not to get pregnant. As in the case of this woman now, her ejection fraction is above 55%. Yeah, she can't get pregnant, but you must counsel her. Counseling is important. That her cardiac function can still deteriorate, at any time. So it's important for patients to understand the risk, both maternal and fetal, before embarking on such. So so the recommendation is that they must always be counseled. Okay? And if someone's LV function has recovered, they can make an attempt at getting pregnant. So it's also important to know that it's not every heart failure in pregnancy that is because of peripartum cardiomyopathy. Okay? Some of them are because of other things. You recollect the other time I said that in this part of the world, in non-Western countries, valvular heart disease, rheumatic valvular heart disease predominates. So this woman was just discharged from our ward this week, 33-year-old, hypertensive. They called us because, obstetrics called us because they were having problem with her blood pressure and they thought she had chest infection. But when my senior registrar saw, she felt that she was in heart failure. And we listened, carefully. There was a diastolic murmur, along her left sternal border. And when we did our echo, the echo showed features of rheumatic aortic valve disease. Okay? So it's important to understand that everything is not PPCM, because if you don't make the correct diagnosis, you're going to deny the patient, timely intervention, and that will not be good down the line. So it's important that for patients who have severe valvular diseases, they cannot get pregnant. Someone has severe aortic stenosis, mitral stenosis, they can't get pregnant. So they must have their intervention first, before getting pregnant. And this is very, very important because for young women contemplating pregnancy, you may want to try a bioprosthesis instead of a mechanical valve for them because of some of the problems associated with anticoagulating them. And the next example, illustrates this perfectly. So I've been seeing this lady for many, many years. She had a mitral valve replacement in 2015. She came to the clinic at 5 weeks gestation, that she was pregnant. And She was on warfarin 6 milligrams and an INR of 2.6. So the challenge was, what do we do with her? Okay, should we continue warfarin for all trimesters or change to low molecular weight heparin? That's very expensive, especially in the setting of Nigeria of today, where everything is jackpine. You know, as doctors are jackpine, dollar is jackpine, everything is jackpine. So that can be difficult. Or should we change to drugs? Drugs are direct oral anticoagulant. Or should we change to unfractionated heparin? So what did we do? So we decided to replace, because this was 5 weeks. So we replaced our warfarin with enoxaparin. But 4 weeks after, she came back to the ER, you know, with a stroke. You know, a CT showed an infarct in the internal capsule. And it was then that we now found out that instead of taking our enoxaparin 40 milligram BD, because of cost, she was taking it daily. So, you know, in conjunction with other specialists, you know, I said the other time, people who have, you know, cardiovascular disease, it must be in a center where you have a pregnancy heart team. So the neurologist, the cardiologist, the obstetrician, the hematologist, we put our heads together, and a day after the stroke, we placed her back on the Clexane, 40 milligrams BD. And then we counseled her and her husband very well. Apparently, she didn't tell her husband. So that one was furious that, oh, you didn't tell me that it was twice a day. You know, why would you be taking once a day, you know, on your own? And she made full recovery. And when it got to the second trimester, we changed back to warfarin. So there are a couple of methods that you can actually use. If someone has warfarin of less than 5 milligrams, you can do that. The risk of fetal embryopathy in the first trimester is lower. But anybody above 5 milligrams of warfarin, then you have to do any of these other methods. So we opted for the second method, and at 36 weeks, we placed her on Clexane. That was what we used. We didn't use unfractionated heparin. The other alternative is maybe for people who are very rich, like Dr. Iseko, you know, they can do low molecular weight heparin, you know, throughout. So I also want to use these two examples to illustrate, you know, why we should be careful with thromboembolic phenomena in pregnancy. You know, as we always say, pulmonary embolism is a great what? Great what? Masquerader. Do you understand? So you really, really have to be careful. So this 38-year-old was my patient. I was managing her for hypertension. She had seizure disorder. She got pregnant, fell. She was trying to cross a ditch and went to a primary care physician who put up a POP. And according to the physician, offered her Clexane, but the patient refused because she was not sure that it was safe because of her pregnancy. So about a week later, she presented to the ER with severe hypoxia and chest pain, and she was dead. Okay, so it's important. The lesson here is that when you suspect cardiovascular disease, when you see cardiovascular disease, you must, for our primary care physicians, our obstetricians, you must refer patients like that to the specialist, because we would have been able to convince her that Clexane is safe, you know, for you in pregnancy. So this was just a life lost unnecessarily. There was this also 41-year-old physician, an asthmatic with IVF multiple gestation, who was having chest tightness, and she felt that it was her asthma and kept using, you know, her asthma medications, only for her to slump and die. And when an autopsy was done, it was pulmonary embolism. So please, these are things that we have to be careful about and refer accordingly when we should. So we just talked a lot about arrhythmias. Okay, so I'm happy that although it was a bit like bamboozling, yeah, but it's quite straightforward. Dr. Isako will be taking us on ECG very shortly. So this 41-year-old hypertensive with gestational DM presented, it was obstetricians that called us with palpitations. So her heart rate was 179 beats per minute. And she was at 28 weeks. Blood pressure was good. She had no symptoms whatsoever. So a modified Valsalva maneuver was tried. It was not successful. We did our echo later, which was normal. So this is our ECGs, as you can see, showing the heart rate of 157 beats per minute. So you can see that it's very fast, and that the QRS complexes are narrow. You know, unlike the ones we saw the other time in the last presentation by Amina and Dr. Amina and Dr. Chima, the QRS complexes were wide, but these ones are narrow, okay? And there are no P waves. So when you see something like this, you say the patient has supraventricular tachycardia, okay? So, and what we did was that initially we tried metoprolol and digoxin. It didn't work, but we eventually gave her IV adenosine. You remember this patient? I think we discussed it. Yeah, we gave her IV adenosine, and the rhythm reverted back to sinus, and we were able to discharge her on metoprolol and digoxin. So the lesson here is that, you know, for your SVTs and your VTs, patients who are pregnant and are unstable, DC cardioversion is safe. You can shock them, you know, not the general physician, no, but the specialist, you know, okay? So you can shock them. DC cardioversion is safe in pregnancy. The other medications that are safe, you know, metoprolol is safe, digoxin is safe. Atenolol is not safe in pregnancy. So we should not give our patients atenolol for whatever reason, whether they're having palpitations or whatever, because of its effects on the fetus. Okay? Amiodarone is also what you don't want to do during pregnancy because of the many problems, you know, fetal bradycardia, fetal thyrotoxicosis, hypothyroidism, and all whatnot. Okay? And for coronary artery disease, yes, you can also see that in pregnancy, and it's not so common. But one thing is peculiar about it, and that is that the major cause of coronary artery disease, or MI, in pregnancy is what we call coronary artery dissection of the coronary arteries. So, you know, this doesn't follow what you see typically in the general population. So the lesson is that when you see any pregnant woman with chest pain, you must do an ECG and you must do a troponin. Okay, so that if these are abnormal, you know, you can refer them appropriately. And the primary, the treatment of choice for MI in pregnancy is primary PCI, you know, percutaneous coronary intervention, which is very possible at CardioCare. So once you see someone chest pain, you do an ECG, you do a troponin, it's abnormal. That type of pregnant woman should be referred to a specialist center. Okay, and of some mention is pulmonary hypertension and Eisenmenger syndrome. I have a patient like that presently that I'm managing, a young woman, 40, no children yet, has Eisenmenger, irreversible pulmonary hypertension from a large VSD. Okay, so, and she's been begging me, doctor, what are we going to do? You know, I said, there's nothing we really can do. You know, what you need is heart and lung, or heart-lung, you know, transplantation. So patients who have severe pulmonary hypertension should not get pregnant. It's one of the high-risk conditions that I mentioned the other time. And, you know, in these patients, when you suspect that they have pulmonary hypertension, especially you do your echo and the tricuspid regurgitant velocity is above 3.4 meters per second, they are candidates for right heart catheterization, which can be performed under strict, you know, conditions during pregnancy. And this is also available in CardioCare too. So with respect to labor, delivery, and breastfeeding, for most cardiovascular diseases, vaginal delivery is the way to go, unless you're dealing with severe pulmonary hypertension or severe valvular problems. So typically, CS, I know a lot of our obstetricians will disagree with this, but the guideline recommendation is that CS should be for obstetric, you know, reasons, essentially. So the other important thing for our primary physicians, obstetricians, is that before you give any drug to any woman that is pregnant, you must check whether it is safe, because not all drugs are safe in pregnancy. So number one, you want to find out whether they are safe. You know, a lot of the medications I talked about are safe, can be used. That's one. Two, you want to find out whether data is limited on their safety. So a good example is amlodipine and nifedipine. We said that nifedipine is the second line. Extended release nifedipine is second line for pregnant hypertensives. Now, amlodipine is not recommended because it is the data on its safety is limited. Okay, so that's why it's important to check, before you give a woman any drug. And the last thing is if it is unsafe, or not. So there are many medications, we've talked about some of them today, Abiodun and what have you, that are not safe in pregnancy. So in summary, pre-pregnancy counseling is recommended for all women. Any woman who has a cardiovascular disease, they must be counseled. It's important to know whether they can get pregnant or not. That's the first question. If they can get pregnant, what adjustment must be made? What are the risks to the mother? What are the risks to the baby? So this is very, very important. And for patients who have cardiovascular disease, prompt referral is very, very important. It's essential. Okay, we talked about hypertension, and we said cardiovascular disease in pregnancy should be managed in centers with multi-specialty pregnancy heart teams. And in those who are moderate to high risk of cardiovascular disease, pregnancy should be discouraged as much as possible. Thank you.
Any questions? We'll take like 3 questions. Mr. Jude, or who is handling the microphone? Can somebody handle the microphone?
Thank you for a good lecture. Mine is more like a comment, because this continuous hammer on not allowing the patient to get pregnant, they will end up in prayer houses and the mountains. How do we handle such issues? Because that's the usual things that happen. You ask the person not to get pregnant and he ends up with a pastor or an imam. I am thinking that, is there no way we can get ahead across such threats of don't get pregnant, because they won't end up, they will leave the hospital entirely for you.
Well, thank you, sir, for your question. That's an interesting question. I think what I've said is that for patients who are at high risk of cardiovascular disease, we should encourage them not to get pregnant, because the mortality rate very high, as much as 50%. Okay, so it's important to sit down with the patient, and not just with the patient, with the family of the patient. The husband has to be there. Typically, in my clinic, I tell pregnant women, when next you're coming, come with your husband. It may also be important to, get the mental health, the psychologist, involved. Everybody sits down. We talked about the concept of the cardio-obstetrics model, in which you involve everybody, as a community. The woman, the husband, other important people in their lives, if they so consent to, as well as other specialists, to counsel them and to give them support, psychological support. I think if you do that, they would, understand that it's important for them to avoid pregnancy as much as possible. Now, if there are issues that can be sorted out, like somebody who has severe valvular disease, I mean, that's a temporary problem. Sort out your valve problem, and then we can then talk about getting pregnant. Okay, and so it's very. I know that in some other parts of the world, we said 50% mortality. I mean, if you're going to try it, it has to be in a place with a multi-specialty pregnancy heart team. I think that's what.
There was somebody down there.
Good morning, all. Thank you very much, sir, for the educative presentation. I have one question. As part of the normal signs and symptoms in pregnancy, you mentioned basal crackles as one of the normal signs in pregnancy. Please, sir, can you shed more light on that?
Okay, so just like I talked about orthopnea too. So typically what happens is that there's an increase in the cardiac output, and when they lie recumbent, okay, you have redistribution, of blood, to dependent areas, and one of such areas is the lungs, okay. And because the lymphatic system, do you understand, may not be able to cope with quickly draining, fluid because of the increased hydrostatic pressure, they can develop basal crackles. So of course, you then have to look out for other things that may be suggestive of pathology. Of course, if I see a pregnant woman with basal crackles, I'm not going to assume that it's normal. That patient would have ECG, would have echo, would have NT-proBNP, would have everything. But the point is that it's possible, that the strain pregnancy, imposes on even the normal heart, is considerable. Not to now talk of the heart that is has poor cardiac reserve.
Yeah. Thank you, the lecturer. This question is for the definition of hypertension in pregnancy, just for clarification. The 140/90 and above is very clear. What of the second definition of rise in systolic and diastolic blood pressure compared to the initial blood pressure readings before pregnancy? We were told that any rise in systolic 30 millimeters of mercury and above, and diastolic 15 millimeters of mercury and above at any other point during pregnancy makes for diagnosis. What is your view about that?
Okay, thank you, sir. Well, we're talking about standards, current standards and protocols. So as at 2023, that does not apply, in any of the guidelines with respect to the definition of hypertension. So for you to see someone has hypertension now in pregnancy, as of 2023, there has to be persistent elevation above 140/90 millimeters of mercury. You remember that there are so many hemodynamic changes going on in pregnancy that can account for something like that. But so long as it is not persistently above 140/90, you cannot say someone is hypertensive.
Final question. Final.
Okay, thank you, sir, for your presentation. One of the few take-home points I had from that presentation is that, first, you have a myriad of clinical scenarios that can present. Now, it shows that you need to have high clinical suspicion first, and the need for early referral. But then looking at the population you are talking about, it may be difficult to easily bring out the patient that has an actual risk. So is there a kind of a protocol where you make it easier so that you won't either under-intervene or over-intervene? You understand? Then that is my question. A comment on the side. For labetalol as a form of treatment for hypertension in pregnancy, I want to say we should also be aware of contraindication in asthmatic patients. We should always ask that before you give, so you won't fall into problems.
Yeah. Thank you for that. That's a very, very good addition. So so for labetalol, asthma, it's a contraindication. Of course, because it blocks both alpha and beta receptors. So that's very important. We must always ask. Now to your first question. Well, the way to go really is to, like I said in my presentation, to take a detailed history, and examine. I don't think there's any protocol that is better than that, taking a detailed history and examining your patient. And if you suspect, that the patient may have a cardiac disease, I don't think it's out of place for you to refer, do you understand, such patient if you are in a primary care setting. Okay? I'm going to be angry if you send a patient that you should not send to me. But beyond that, there's nothing I can do really, yeah. And at the end of the day, we're talking about mortality, and morbidity here. So I think erring on the side of caution, is better, than, allowing that to go.